Amyloid is all over in the air, but we are not diagnosing it. Dr. J.C. Mohan in his talk in 2022 has said that at least very conservative estimate of 1,90,000 ATTR in our country, and hardly less than 10 have been reported. Some people have said they are diagnosed, but reported cases are extremely low. The big series from two big institutions which was published did not mention ATTR amyloidosis, which is the one which happens with aging. But why should you look for amyloidosis? It is because cardiac amyloidosis, is a mortal disease. Dr. Samir just now mentioned that absolute contraindication for a TAVR or SAVR, less than 1 year life expectancy. With AL amyloidosis, the life expectancy without treatment varies from 4 months to 12 months. And with chemotherapy, it can be prolonged. What about senile or ATTR? It may be as long as 5 years. But still, for death within 5 years or average life expectancy of 5 years shows that it is a mortal disease. So if you miss amyloidosis, then you are missing a major disease which can kill. So these are the questions we should ask before making a decision or before answering the question. How frequent is the association between aortic stenosis and transthyretin cardiomyopathy? Is it a simple epidemiological association or is it a causal relationship? In which patients with aortic stenosis should we search cardiac amyloidosis? To what extent does cardiac amyloidosis affect the results of TAVR or SAVR? And what are the implications of coexisting cardiac amyloidosis and aortic stenosis in clinical decision making? So first question, how frequent is the association? And there are many papers where roughly it is about 16-20%, but that is high. 20% means 1 out of 5. So the thousands of TAVRs have been done in our country. Thousands of SAVRs are being done in our country. How many have been looked for amyloidosis? I would dare to say none. And low flow, low gradient physiology, but 78% of them had amyloidosis. How many we are looking for? Very low. And important thing is the mortality with aortic stenosis and amyloidosis was quite high. You can see the graphs vary, the worms were separate very much and very early. So if you miss amyloidosis, you are in short harming the patient, or at least harming the patient's pocket. So it's a simple epidemiological association or a causal relationship. The answer is not yet resolved, but there is a hypothesis that there is an interaction between the AS prime myocardium leading on to deposition of amyloid. So AS can lead on to amyloid, and some people think that happens vice versa also. Amyloid can lead to aortic stenosis. One of the reasons of rapid progression of aortic stenosis, you see 1 year back, it's mild and later it is severe. It is not a wrong echocardiography. It may be underlying amyloidosis. In which patients should aortic stenosis, we should actively search for cardiac amyloidosis. The question was, should be in or, but certain situations we should actively search. And so how do we search for it? That's the first question. So cardiac amyloidosis, there are certain red flags. Carpal tunnel syndrome, if they give a history of carpal tunnel syndrome, definitely yes. ECG, low voltage despite LVH. So you see a low voltage in your ECG of a patient with severe AS, think of amyloidosis. Disproportionate, very high elevated troponin or BNP. Sometimes the troponin may be as high as thousands. And of course, biventricular hypertrophy, sparkling, and GLS is something which I am very fond of. The cherry on top appearance is less common. And the CMR, the Dr. John Christopher will talk about that. Confirmation is very simple. Bone scan, bone scintigraphy, which costs between 3,000 to 6,000 rupees in our country. Imagine we are doing procedures worth 20 lakhs, 30 lakhs, and why can't we spend about 6,000 or 10,000 rupees to screen? And also you have to roll out AL by doing kappa lambda ratio as well as urine or serum immunofixation assay. And there are specific treatments. In aortic stenosis patient, the important thing is it's a very fast progression. and paradoxical low flow, low gradient aortic stenosis. And they have to be seen by a heart team and they should be fully assessed. Echo is an essential tool, but there's no one finding which it's pathognomonic. Echo alone are not diagnostic and cannot differentiate between AL and ATTR. So certain phenotypes we should actively look for amyloidosis, which include low flow, low gradient, reduced ejection fraction, and myocardial contraction fraction. And there's what is called a triple 5, E prime, A prime, S prime, less than 5. Or at least look for S prime if it's less than 5. Look for amyloid, because you may be actually saving the patient by diagnosing amyloid. And other things include QRS voltage versus left ventricular mass, etc. There's an entire multiple things are there, but the topic is should be searched. This is my personal favorite because very easy and it's very glaring. Many times the echocardiographer calls us and says the EF is 60%, GLS is 10. Should I call it LV dysfunction or not? And I say look for amyloid, and lo and behold, we have picked up many cases with this. Extremely simple, cost nothing, and 3 minutes extra. So what are the implications of the coexisting amyloidosis and aortic stenosis in decision making? The next talk is about the decision of valve replacement. I will not be going into it, but you can do AV surge SAVR or TAVR, and this the surgery or the procedure itself is not dangerous, but compared to TAVR, SAVR may be more dangerous because of the implications of amyloidosis on anesthesia and need of pacemakers. And to what extent does amyloid affect the results of TAVR or SAVR? The important things are, I'm not going to technical details, but there are problems with cardiopulmonary bypass. There can be inappropriate hypotension. We had one patient who went into extreme hypotension, and then we had to fill her up very, very, very aggressively. And there's other things are, these patients are prone for heart failure. So if you do not anticipate heart failure, you might have done a wonderful TAVR or a SAVR, and within months, you will end up with a patient with heart failure with restricted lifespan. And anticipate pacemakers. And if you anticipate, be ready. Downstream management, again, the important things are the pacemaker need. The anticoagulation is very important. So the anticoagulation is very important because amyloidosis is a high risk of thromboembolic complications, and this is one situation where the CHA2DS2-VASc score may be low, or can have a low CHA2DS2-VASc score for starting anticoagulation. And some people have even gone to the extent of saying even if normal sinus rhythm anticoagulate, that is controversial. But an interesting concept is atrial electromechanical dissociation. That means no atrial contraction while remaining in sinus rhythm on ECG. And you may think it is rare, actually it's not there, and about 20% of the patients can have. The problem is they are at very high risk of embolic complications. So atrial electromechanical dissociation is something which we should actively look for. So anticipate the need for pacemakers. Indications for ICDs are still debated. And finally, last but not the least, there is targeted pharmacotherapies are available in our country. So Claudio Rapazzi in this very good article said the aortic stenosis and TAVR and TTR are we progressively unraveling the tangle. It had been a total tangle altogether, but slowly we are unraveling it. So should all patients with severe aortic stenosis undergo amyloid screening? And my answer is a qualified yes. Everybody, maybe not, but some reasons for look for. One is amyloid is common but underdiagnosed, especially in elderly. Decision making, SAVR is dangerous, TAVR is preferred. Anticipate, higher heart blocks and pacemakers. Patient decision making and prognostication. If their life expectancy is less than 1 year, why go for all the trouble and spend money? Anticoagulation issues in low CHA2DS2 score, normal sinus rhythm, and atrial electromechanical dissociation. It's a very cheap to test. It costs, overall testing may cost even less than 10,000 in topmost corporate hospitals. If things are not that costly, it may be in low thousands. And if untreated, amyloidosis can be fatal, and they have specific treatments. So ultimately, we are treating the patient, not the valve. That's what we have to decide. So we should have a cardiomyopathy aware mindset. Both the interventionalist, echocardiographer, the basic cardiologist, and the referring people all should have a cardiomyopathy aware mindset and recognize the red flags and rational selection of further diagnostic tests. Conclusions: 15% of patients may have AS and TTR amyloidosis. Think of the red flags, especially carpal tunnel syndrome. Look for low flow, low gradient pattern, and low GLS. And symptomatic patients should be assessed by heart team. TAVR may be preferred to SAVR, and there are targeted therapy, tafamidis is available in our country. So the fate of cardiac amyloidosis and aortic stenosis, hopefully no longer it should be like what the eye doesn't see and the mind doesn't know doesn't exist. That's what we have been thinking. We think that aortic stenosis doesn't exist. Ladies and gentlemen, it exists. Look for it and you may find it. Thank you very much for patient hearing.